Welcome to the third session of Mini Medical School, The Hidden World Within, the Gut Microbiome. My name is Levi Teigen. I am an assistant professor in clinical nutrition in the Department of Food Science and Nutrition at the University of Minnesota. We are excited to have you here today. If you've been with us this whole time, a quick reminder that we covered gastrointestinal basics in session 1 and introduced the gut microbiome last week in session 2. Both of these are available on the Office of Academic Clinical Affairs YouTube channel if you are unable to attend or would like to revisit these topics. Today we will draw on the first two topics to showcase truly cutting-edge, patient-centered work being done here at the University of Minnesota. We will begin with a moderated discussion, followed by a question and answer session. You can submit your questions to our panelists at any time using the Q&A box. This can be found by clicking on the Q&A button at the bottom of your Zoom screen. Please note that the session is being recorded and will be available next Monday on the Office of Academic Clinical Affairs YouTube channel. We will share the link to the recording with you by email. Today we have the privilege of speaking with a panel of truly exceptional physician scientists who are pioneers and leaders in the application of microbiota therapeutics, and as you'll see, all driven in their work by a strong desire to advance patient care and outcomes. Now I would like to introduce our first panelist, Alex Khoruts. Dr. Khoruts, who is the pioneer I mentioned, is a professor in the Division of Gastroenterology, Hepatology, and Nutrition. He is also the director of the University of Minnesota Microbiota Therapeutics program. This incredibly unique program manufactures different therapeutic formulations of fecal microbiota, which are being tested in multiple clinical trials. Dr. Khoruts, can you discuss fecal microbiota transplants, what they are, and their implications for treating gastrointestinal conditions?
Well, thank you so much, Levi. Let me share my screen. So I will take you through a brief overview of how the gut microbiome has become a frontier of new therapeutics development. I have a couple disclosures. I and the university have some patents pertaining to purification and cryopreservation of extracted gut microbes. And recently I became a co-founder of a company called Gut-Brain Axis Therapeutics. My story here starts with a patient back in 2008. That's in general gastroenterology clinic. This patient was a 61-year-old woman who came in with an 8-month history of chronic diarrhea. It started with some antibiotics, and then through these 8 months, she had several hospitalizations for dehydration and received more antibiotics. She was quite miserable. She was having bowel movements every 15 minutes, 24/7. She literally lived confined to a wheelchair, and at that point, she had lost 60 pounds of weight. The disease that she had has become a foundational disease for this field. She had an infection with a bacterium called Clostridioides difficile, and she actually had a severe form of it called pseudomembranous colitis. What you see on the left side of the screen are these yellow plaques or pseudomembranes, which are literally explosions of pus that are trying to contain the damage that's done to the lining of the colon. And that comes because of the C. difficile bacteria make toxins that damage those cells. On the right side, you see a healthy colon. You know it's healthy because you can see little blood vessels. That's how we know that the lining of the colon, or so-called mucosa, is pretty thin. And the endoscopist can see that. You cannot see that when there is colitis. So here's the basic overview of this disease. It is a complication of healthcare, of antibiotics. Antibiotics, whatever the indication may be, disrupt the microbes in your digestive system. So your digestive system, as you've learned in this medical school so far contain a community of microbes. It's part of our normal physiology. And whenever you take antibiotics, you're literally throwing a little grenade or perhaps a big grenade in there. And that microbial community gets disrupted and becomes vulnerable to invasion by opportunists like the C. difficile infection. While this sneaky bacterium, once it lands in the colon, it actually finds a home there and it starts thinking, how do I infect more people? And the way to do that, of course, is to cause diarrhea. And so it wants to cause damage. It doesn't care about the host, it cares about itself. It makes toxins. And that's what causes that pseudomembranous colitis. And of course, it's an infection. So, what do we do with an infection? We treat it with antibiotics. Well, the problem happens, it's one of the challenges with this particular infection, is that yes, the antibiotics do subdue the infection. And indeed, the patient gets better. The problem is they can't completely, in many cases, completely eradicate C. difficile because it knows how to evade antibiotics. It can make spores and just hide and wait, or sometimes it can contaminate the environment or find biofilms or whatever the mechanism is. The problem is when you stop the antibiotics, the microbiome is even more depleted than it was at the beginning, and those spores are germinate and the infection starts up again. And this is what was happening to this lady. And so the treatment in this case, as she has failed repeated cycles of antibiotics to try to subdue this infection, I started thinking about an old therapy, which is, well, how about we just fix her microbiome by a transplant? And this is exactly what we did. Now, this was 2008. It literally took me another 7 months of really trying to cure her with antibiotics and as well as get through some regulatory checkpoints so we could actually do this. The treatment itself at that time was rather crudely constructed. It had several critical components. You need to have courage and determination. That's key. Really needed a lot of nursing help. It's another key. A few simple tools would suffice. A blender. I thought, I mean, I'm a gastroenterologist, I can put a scope in somebody's colon and deliver the microbes exactly where they have to be. So that was the preferred method. I won't go into too many details of how it went, but I was happy that we were able to secure an entire afternoon for this procedure. And frankly, the nurses were running around for hours afterwards with air fresheners trying to clean it up. However, the patient in the recovery room, now 15 months into her illness, said, I feel different. And she was cured. And this case really became a foundational case in the entire world. This was the first time that we documented, anybody documented, that microbes from a donor made their home in the recipient. People actually believed at that time that that was not quite possible, that the remaining microbes there would resist the such colonization. But now it's in retrospect, of course, it seems obvious. That's what was going to happen. This case report was published in a scientific journal. It was picked up by the New York Times and published in 2010. And I had um, essentially a Niagara's Fall of emails that followed from readers of New York Times with all kinds of digestive questions of how that could be fixed. So here's another illustration of what this does. So on the left-hand side, you have a donor microbial community. This is just looking at some key bacteria, and which in the names of the bacteria don't matter. This, what you have to get out of this is that the microbes are not random microbes. This is an organized microbial community where individual species work together. They have relationships. And so these green lines indicate positive associations. That is, when these lines connect to microbes, they work together. It's just like a community of people in a way. You can imagine for a functional community of people, you need all kinds of people. You need hairdressers, you need mechanics, you need builders, you need computer analysts, etc. Maybe a few lawyers, a couple doctors. And then what happens in a patient like this? So a patient before what became known as fecal microbiota transplant. In fact, that name originated mainly based on this case report. It's a name that we came up with. Um, Prior to that, it was known as by other names, most commonly fecal bacteria therapy. Anyway, you can see the patient who's been pummeled with antibiotics, that microbial community is literally devastated. And in fact, the residual microbes that seem to be hating each other with the red lines connections. And then 1 week after, you look once again, and that whole microbial community is reconstituted. This is a fundamental concept in that in this kind of condition, when we are really trying to repair major damage to the gut microbiome, you're not going to fix that with some probiotic. Now, we published that in 2010. The fact is that this infection was not a rare thing. About 500,000 people get C. difficile infections per year in the United States, and about 100,000 get this recurrent form. And it's still considered a major threat by the CDC. It kills about 15,000 people a year. And so I wasn't the only gastroenterologist who was confronting this kind of problem in the office. This was happening all over. And so people started doing this procedure more and more often. Now, I should note, given that this is University of Minnesota, there is a prior history to this. Back in 1960 or so, this was practiced back then. Dr. Wangenstein, who was head of surgery at the time, was doing this with his patients. Then a drug came out called vancomycin, which kind of kept a lid on this and still helps for a couple decades. But then it started failing. And so people started doing this, and the FDA got a wind of this, and they got us together in a public workshop, and they said that we made a determination that fecal microbiota, when used to cure, treat, mitigate, or prevent a disease, and this is language written by the US Congress, fecal microbiota for transplantation meets the legal definition of a drug and biologic product. And that's the regulatory paradigm in the United States, actually the only country that has this particular framework for this therapy. But it does matter. And so, drug or not, actually, one of the reasons we called it a transplant, we were hoping there was going to be kind of a blood bank-like therapy. And you could have nonprofits and such and keep the costs down and make it available. That didn't quite happen. Well, anyway, if it's a drug, we're going with that paradigm, and there are certainly advantages with that, although a blood bank model would have worked just fine. And so we are fortunate at the University of Minnesota in that we have a facility that can manufacture drugs that operates in accordance with pharmaceutical standards. And this is not a trivial thing. There's not many institutions have something like this, but it exists at the University of Minnesota specifically for the purpose of doing early phase clinical trials and making sure that you're making a drug, an investigational drug, with full controls. You have full documentation. You know how every step is occurring. You're ready for FDA inspection on any day. And in fact, we have been inspected by the FDA and passed it just fine. Um, and this is what basically was started working on over the, I guess, since I treated the first 10 patients like I did the first one, it became pretty clear at the time this was not going to be mainstream medicine. We had to standardize this. We had to create a manufacturing process. So this is the different products that have emerged out of our program over time. One up above, frozen liquid formulations are still being used. And our next speaker, Alexa, was a key person that helped to develop it. at the time. And she was at the time was a young graduate student in our program, and was part of her PhD to figure out how it works in C. diff. But we have capsules, and more recently, we developed a powdered formulation that you can just put in a drink. And the reason we did that is because many of our pediatric patients in different diseases could not swallow the capsules. Now, of course, the question will come, well, who are these donors that you're making this material from? Well, we had to build a donor program, and that was an endeavor of its own. Um, we recruit the healthiest people. So that means that they have no medical diagnoses, no surgical history, no prescription medication. They're metabolically fit. They're basically Greek gods. But more importantly, or at least as importantly, we trust them. We build relationships with them. These people are under continuous surveillance, you could say. They have to fill out questionnaire after questionnaire. They're monitored all the time. They're tested for COVID every 2 weeks. They have blood tests every 2 months or shorter intervals. And of course, we test every batch of production is tested for pathogens and antibiotic resistant organisms. And that's until everything is checked off, the material sits in a cryobank and cannot be released. That was a key part in the development, is that you can't just blend stool like I did the first time, and just assume it's safe. Now, in that first case, that was the patient's husband, and presumably they shared all the microbes already, and that was okay. It was already kind of standard medicine at that time. It's not quite standard today. So the FDA wants to make sure everything is safe, and so it sits in the cryobank until it can be released, passing all the tests. Now, I said something about the donors and the importance of trust. And this may be a drug, but it still has transplant qualities. And our donors are our partners, really. This raw material is supplied by humans. And this is more than just being a blood donor. They have to commit to intensive and long-term participation. We do a lot of tests. And when you do a lot of tests, some of these tests can come up abnormal. And that can create anxiety that the donors didn't ask for. And so our program takes responsibility of that. And if something is abnormal, we carry it to the conclusion and provide appropriate counseling. There's also a moral hazard of monetary compensation. So, if you're going to pay for it, that creates a relationship that's no longer trustworthy. So yes, we do reimburse a little bit for the effort, but consider that the donations have to happen in a supervised bathroom and all the other stuff that the donors have to commit to. So we actually had a focus group. How much can we pay just to say thank you, but certainly not enough that this becomes a financial reward for somebody. And that's how our institutional review board looked at it. Now, this is a slide that probably summarizes why most of you are here. When I started this journey, I thought, and that was almost 20, that was 20 years ago into the microbiome. What I saw was emergence of technologies that could finally look at the microbes in the gut in a systematic way. You couldn't do that in the past by culturing something in a petri dish. You had to look at the whole community. And so what I saw really at that time is a series of papers that showed me that literally within my own lifetime, an entire organ was being discovered. And I'm a gastroenterologist, and this organ is discovered in my specialty. So at that time, I had to make a career choice of, I was largely an immunologist before then. Like, what is it I'm going to focus on? Well, it turns out this gut microbiome is really um, integral to our entire physiology. It interacts with our immune system. It sets how it develops. It interacts, obviously, it is part of how the gut works, and it's a major metabolic organ. It's only second to liver in terms of chemical transformations that are happening in our body. And those metabolites, the byproducts of those reactions, talk to the rest of the body, including the brain. Um, our lifestyle, whether we exercise or sit around, has an impact on the microbiome, and the microbiome also has an impact on how we exercise. It's a unique organ and that's open to the environment. You've learned obvious, and it's obvious that the diet has a huge impact on what those microbes do. Social networks, who you communicate with and who you hang around with, also make an impact because we don't live in a sterile environment. Now, when it becomes sick, all these inputs starts matter, and all these relationships start matter, and therefore there is a lot of interest besides conditions like C. difficile infections, where the microbiome is just depleted with antibiotics, of how it contributes to other diseases. And that has really become the major direction of our program. And so, because we developed all these products, mainly the encapsulated formulations of freeze-dried microbial communities, we now have a network of collaborations, some in our institution at the university. A lot of them are across the United States, and they address a variety of clinical disease states. Not surprisingly, there's a lot of interest in digestive system disorders like inflammatory bowel diseases of ulcerative colitis and Crohn's disease. Um, we have a trial in a variant of this called primary sclerosing cholangitis, where it's also associated with inflammation of bile ducts. And we have a huge arm of investigations in the gut-brain connections, particularly autism. But there's interest in Parkinson's disease. We have a NIH-sponsored clinical trial on alcohol cravings in liver disease patients. If you think about it, the your immune system, we think of it as just fighting invaders and pathogens. Well, on a daily basis, your immune system is actually interacting mostly, as far as microbial world is concerned, with your own microbes. So whatever happens in your gut can calibrate immune responses. And therefore, there's a lot of interest in gut microbiome in autoimmunity, food allergies, and a multitude of conditions. I'm just listing some of the clinical trials that are ongoing. Cancer recovery is a huge area. And here we have like two situations. One is bone marrow transplantation. Now that's in that case, in order to change somebody's immune system and reset their bone marrow, they go through body irradiation and intensive chemotherapy that kills their immune system, sloughs off their gut, um, and they have to get antibiotics because they're very vulnerable to infections. Well, that depletes their microbiome. And then you're asking their immune system to recover in the setting of a depleted microbiome and fighting with potential pathogens and antibiotics. And you have complications like graft versus host disease because the immune system doesn't quite emerge all benign. So prevention of graft versus host disease is a big interest. At the same time, immunotherapy has become a huge area in cancer, where you're trying to harness the power of the immune system to target the tumor. Well, it turns out if patients get antibiotics, it doesn't work as well. And it's because the immune system is miscalibrated. Antibiotic resistance, the more antibiotics people get, and that's an urgent threat in our society. It's literally a tsunami that's waiting to happen, or a medical equivalent of climate change crisis, where in a couple decades, it's projected more people will die of antibiotic resistant infections than from cancer. Um, I have a couple trials in cardiovascular health. That's a sampling of the broad scope that we're doing. I'm not even mentioning Cyrus's work here because he'll talk about it himself. Um, Now, you should contrast, and it's just often misunderstood. When we do this treatment for C. diff, where the microbiome is completely depleted, it's actually fairly easy. All you have to do is infuse a normal community, and magic happens. When you're trying to do these other conditions, you're trying to change the entire microbiome, it's much more challenging. Those skeptics back 20 years ago who thought this was not possible were kind of right. It is not that easy to change somebody's microbiome. So these autism, for example, regimens are very intense. There's an antibiotic conditioning, and there's a dosing of donor microbes that happens for like 2 months. Uh, and you can't just like throw in different microbes and think you'll cure it. You have to understand the mechanism. So there's a lot of research that has to happen mechanistically. This form of therapy, we don't call it FMT, we call it microbiota transplant therapies or MTT to make a distinction. And it's also important to think what happens after you do that. Now, for example, in C. diff, okay, so we gave an inoculum of healthy microbes, but the patient lives in the hospital, it interacts with sick people, it eats bad food. What's going to happen? Are these microbes going to be nurtured to health? Very few have attempted to study this question. We've tried, and this is one of our uh, projects going together, and Dr. Teigen is involved in that. So I think of this right now. We're at the very early stage. In right now, we're sort of experimenting. It's like clashing two galaxies together and thinking, well, what's going to happen? Well, hopefully something's good's going to happen. And now, if the C. diff galaxy is very small, good things do happen. Other conditions may not be so simple. So the question is, well, where's the future of this? The future really is in science. So we need to understand, and now there's all these different assays. We need to understand what is making up the microbial community. What are they doing? That's called metabolomics. What are the immune responses to and the participation of the immune system? And how does this networking works? And we have to use a lot of collaborations across disciplines to figure this out. The, the distant future is not entirely clear. Um, it could be that we're going to stratify different donor communities for their particular properties, and that's going to be the therapeutic approach. Or perhaps there are going to be some defined, highly defined consortia of microbes that will be able to be therapeutic. Um, that's all in the future. We have a lot of work to do. And that's our journey ahead. We're just exiting this cave, which is supposed to represent colon. Um, and this is our mission. Okay, we still provide treatments to patients with C. diff infections, and we do it free of charge at the University of Minnesota. Our mission of academic mission is to support early phase academic clinical trials and develop next generation microbiota-based therapies. Of course, there are acknowledgments. This work would not be possible without critical collaborations. One of them is an organization called Achieving Cures Together, which is a nonprofit that was started by one of my patients a while back who felt that his own disease had a higher mission, and we certainly have helped thousands of patients um, with their help. Um, all the different people in my lab, as well as collaborators, certainly thank our donors um, to make the therapeutics possible. Thank you so much.
All right. Thank you, Dr. Khoruts. As a reminder to everyone, please continue to submit your questions using the Q&A box. Our panelists will answer them after all presentations are complete. Now, I would like to introduce Alexa Weingarten. Dr. Weingarten is an assistant professor in the Division of Gastroenterology, Hepatology, and Nutrition. Her current research is focused on microbial and immune interactions in celiac disease and food allergy. Dr. Weingarten, can you please discuss treatment therapies for celiac disease and food allergies?
Of course. Um, okay. So yeah, I want to take some time today to talk about the potential role, I think likely role of the gut microbiome in these diseases and food allergy and celiac disease, and then dive into a little bit of the work that's been done on whether or not we can use our understanding of how the gut microbiome is interacting with the immune system in these diseases to develop new therapies for them. Okay, just as a brief disclosure, I hold the following patent related to fecal microbiota transplantation. Okay, so we know that food allergies and celiac disease are both on the rise. So if you look on the left side of the screen here, this is a graph showing the rates of patients presenting to the emergency department for a food allergy between 2005 and 2014. And it's pretty clear that basically no matter what the food allergy, although more for peanut maybe than for others, the number of folks who are coming in with severe allergic symptoms is really rapidly rising. And then if you look on the right, for celiac disease, we also know that the prevalence of this disease, or the incidence, the rate at which people are being diagnosed, also seems to be increasing. So if you look at studies that were done back in even around the year 2000, compared to studies that have been done in the past couple of decades, or past decade instead, you can really see that the incidence, the number of folks who are being diagnosed with celiac, has increased over this time. So why? Why are these diseases increasing? What's going on? Well, unsurprisingly, there's a lot of factors that go into the development of these diseases. Certainly genetics is a part of it, especially for celiac disease, but also potentially things like changes in diet, medication use, different infections and exposures, and then of course, obviously, as we're here to talk about today, differences in the gut microbiome. And in particular, some of these things, especially genetics, are things that don't change quickly, right? They're really differences that happen over multiple generations, probably not the rate at which we're seeing these diseases increase. So it's more likely to be one of these environmental factors. And in particular, the exciting thing about differences in the gut microbiome leading to differences in the rates of these diseases is that the reverse might be possible. Can we alter the gut microbiome in order to actually treat these diseases? Okay, so for the rest of this talk, I'm going to go through a couple of different topics. One, of course, is to go over what these diseases are in brief, just so we're all on the same page about what we're talking about. And then, of course, I want to talk about whether or not the gut microbiome is altered in these diseases and how. And then finally, what are some emerging treatment possibilities that rely on an understanding of the gut microbiome that are being used to, or may in the future be used to treat these diseases? Okay, so both food allergy and celiac disease are at their base an abnormal immune response to food proteins. So our normal response is to is for the immune system to look at these proteins that come from food and say, these things are great. They're helping us live and grow and continue to exist as organisms. So come on in, they're not a problem. But for reasons, again, we don't entirely understand, they become a problem in food allergy and celiac disease. So what I'm showing here on this slide is what is happening that's gone awry in the immune system during a food allergy. So in a food allergy, you have a particular type of T cell that can recognize food allergens, proteins from food that are driving an allergic response. And again, rather than being a type of T cell that says, these things are great, we're happy with it, instead, these T cells are so-called Th2 cells. It's a type of inflammatory T cell. And in turn, those cells tell B cells, another part of the immune system, hey, I want you to start making antibodies against these food allergens that recognize and bind to these food allergens, and a type of antibody known as an IgE antibody. Now, when those IgE antibodies bind to those food proteins, those food allergens, they can actually bind to and cross-link on a type of cell called a mast cell, which is packed full of these granules that contain things like histamine and serotonin, things that are going to cause the symptoms of food allergy. And when that IgE binds to the mast cell, those granules go out into the wider world, into the bloodstream, into the tissue, and you get the symptoms of food allergy like diarrhea, vomiting, nausea, hives, issues breathing, and then, of course, in most severe cases, shock, low blood pressure, right? Anaphylactic shock. Celiac disease is also an issue of how the immune system responds to food proteins. It's a little bit different than a food allergy. So we know that in celiac disease, it's still an issue at the base of these T cells that are recognizing food proteins, but this time it's T cells that are recognizing gluten proteins from things like wheat, barley, and rye. And instead of becoming now a Th2 cell, they instead become a type of T cell known as a Th1 cell. So still an inflammatory cell, but slightly different type. And these Th1 cells will activate these cytotoxic T cells that reside in the gut and tell them, whoa, it's time to go crazy. And so those T cells attack not even the gluten proteins themselves, but they actually wind up causing damage to the intestinal lining as sort of an innocent bystander in this process. And that damage to the intestine leads to the symptoms that we see in celiac disease, which can include things like stomach pain, weight loss, diarrhea, related to an inability to absorb nutrition because the intestinal lining has been altered. Okay, so now that we have a basis for these different diseases, we can talk about the main focus of the talk, which is how is and whether is the gut microbiome is altered in these diseases and how that might be playing with the immune system to drive or, if we're lucky, prevent these diseases. Okay, so surprising to no one, yes, the gut microbiome is different in patients with both food allergy and celiac disease compared to healthy individuals. So I'm showing you just one example here of a study that looked at the stool microbiome in patients with cow's milk allergy, so actually infants with cow's milk allergy. And what they did is they took samples from these patients and did DNA sequencing on the stool samples in order to identify different bacterial taxa that were present in both healthy and individuals with cow's milk allergy or CMA. And what you can see is that it's pretty clear there are some bacterial taxa that are markedly different in individuals with cow's milk allergy. So there's a set that's in blue that are increased in the stool of infants with the allergy. That's on the left side in blue. And then on the right side in orange are some bacterial taxa that are more abundant. They're higher in individuals that were healthy infants. So yes, there are differences. And then unsurprisingly, we also see differences in individuals with celiac disease compared to controls, those without celiac. This was a really interesting study because it not only looked at differences in the gut microbiome of individuals' feces, but also in aspirates and fluid taken from the intestine where the disease is actually happening, as well as differences in mucosa-associated gut microbes that were attached to biopsies that were taken from the intestines of these individuals. And what's really interesting is that you can see differences between individuals with celiac disease and control patients in all these locations, but the exact bacteria that are different depending on the location. Okay, so yes, clearly we do see differences in the gut microbial composition in individuals with celiac disease or food allergy compared to individuals without these diseases. But a really important question is whether or not these differences can actually cause disease. Is this just a random association? Is this a downstream effect of the disease, or are these differences in gut microbes really playing a role in the development of this disease, of these diseases? So one way that we can answer that question, one way that a couple of investigative groups have tried to answer this question is by turning to a mouse model. So using mice where we can model these diseases, but we can, unlike in humans, we can make these mice germ-free. We can raise them very carefully so they never have any kind of microbial exposure. And with these mice, these germ-free mice, we can inoculate them with bacteria from, or in some cases, more in fecal material from either healthy individuals or those with a food allergy or with celiac disease. And then we can look at what happens to the model. Is there a difference in the outcome of these diseases when they're given healthy versus stool that's taken from an individual with one of these diseases? Okay, so this is again another paper that was looking at whether or not they could recapitulate disease in these germ-free mice if they gave them either healthy stool or stool from, again, those individuals with cow's milk allergy. That, again, we already know those are different, right? But can those differences drive disease? So what you're looking at on the right is how we, one way that we look at allergy in mice. So mice, you can sometimes you can see them itch more, right? You can see them have diarrhea. But one way that we can tell whether or not they're truly going into shock, into anaphylactic shock, is by looking at body temperature. So mice will have a decrease in their body temperature when their blood pressure is low when they're in shock. So we know if we make mouse allergic to a particular food, in this case, cow's milk, and we challenge them with that food, if they have a drop in their body temperature, they're allergic, they're going into shock, anaphylactic shock, right? So what you're seeing on the right then is either germ-free mice, so mice that they didn't get any stool whatsoever. You can see when they get the challenge with the food allergen, they have that shock response, their body temperature goes down. And the same is true if they got stool from an individual with a cow's milk allergy. But mice that received stool from a healthy individual were protected. So yeah, there is actually a difference in whether or not these differences in gut microbes can lead to differences in disease. Clearly, individuals with cow's milk allergy have a gut microbiome that is not protective against them developing the food allergy. And then this was another really interesting study in celiac disease trying to answer a similar question, but instead of using germ-free mice that were in a food allergy model, they gave just standard germ-free mice stool from either, microbes from either an individual without celiac disease or someone with celiac disease. Now, our models for celiac disease aren't quite as good or developed as those for food allergy. So instead of really being able to look at disease, instead what they were able to do is look at whether or not these different sets of microbes had a difference in their ability to break down gluten. Can these microbes, do they have an equivalent ability to break down the causative protein, the protein that's driving the disease in the first place? And the answer is yes, there is a difference. So that's what you're seeing on the right, looking at the amount of gluten in the small intestine of mice that were either given bacteria from a control patient that's with two different genetic backgrounds, or from an individual who had celiac disease. And yep, lo and behold, microbes from individuals with celiac disease were less good at breaking down gluten in the intestine when they were given into these mice. So maybe that's part of the reason why individuals might be more predisposed to develop celiac disease if everything else, if their genetics are permissive of it. Maybe the microbes that are living in the gut of individuals with celiac disease just aren't as good at breaking down the problematic proteins as individuals who don't have celiac disease. And maybe that's why some folks develop celiac. Okay, so with all of this knowledge in mind, what have we learned? What are upcoming and potential possibilities for using this understanding of the gut microbiome to treat these diseases? So as you can imagine, there's a number of different ways that we might be able to manipulate the gut microbiome in order to help patients with these diseases, with food allergy and celiac disease. One that we kind of just hinted at is that maybe we can find bacteria that can actually break down the problematic food proteins. If we make the protein go away, the person will never manifest symptoms of the disease, and we've solved the problem. Another thing that might be a possibility is maybe we can provide individuals with a beneficial microbial metabolite that's capable of altering the immune system, for example, to reverse the issues that we see with the diseases. And then finally, of course, is there a role for delivering entire fecal microbial communities via microbial transplant therapy, like what Dr. Khoruts just mentioned, in order to provide a benefit for individuals with these diseases. Okay, so this is a paper actually from the same group that tried to look at whether or not there were microbes that were capable of degrading food allergens, those proteins in food that drive food allergy, and whether or not that would be beneficial in at least a mouse model of food allergy. So they used a peanut allergy model, which is what you're seeing here. They took mice that they had made allergic to peanut and gave them microbes that were capable of breaking down the peanut proteins. And then when they challenged them with the peanut, they found that those mice did better. So they had lower amounts of the peanut protein in their blood. That's what they mean by systemic access there. And they had lower evidence of lower mast cell degranulation and anaphylaxis. So I mentioned again, those mast cells are kind of the final stage of having an overt allergic reaction, right? Those release of those molecules from mast cells. And the mice that were given these peanut degrading microbes had decreased evidence of that effect, as well as decreased symptoms, decreased anaphylaxis. Okay. Another group has also looked at whether or not particular metabolites from an amino acid tryptophan might be beneficial using a mouse model of celiac disease. So this is not the same as before. These aren't germ-free. They're just regular mice running around in their normal environment. But with these mice, they either gave them a regular diet or they gave them a diet with high levels of tryptophan. Now, there's a number of microbes in the gut that like to break down tryptophan and produce these molecules known as indoles that are derivatives of tryptophan that are really uniquely produced by microbes, not produced by the host. And what you can see here is that when these mice were given a high dose of tryptophan, and I'm not showing this, but they had increases in these microbial tryptophan metabolites in the gut, and they had decreased gut permeability, right? So you're actually potentially blocking these gluten proteins from getting into the body by decreasing gut permeability with high tryptophan. And similarly, along the same lines, these mice had a lower abundance of inflammatory cells in the intestine when they were given high levels of tryptophan in their diet. So that suggests that just by giving these animals tryptophan, that was enough to drive a microbial effect that resulted in a decrease in the celiac disease as it was modeled using these particular mice. Okay, and then finally, again, as Dr. Khoruts mentioned, there is an ongoing phase 2 trial trying to evaluate whether it's feasible and safe to use microbial transplant therapy in individuals with food allergy. This particular group, which is based out of Boston, they had initial promise in a phase 1 trial, so they're actually undergoing again a phase 2 trial with a larger cohort. So hopefully we'll know more soon about whether or not this can also be an effective therapy, at least for food allergy. Okay, and then finally, I just want to thank the members of my lab, my funding sources, and then I'm a member of the Center for Immunology here at the University of Minnesota, and I have a number of very, very important collaborators that I work with in the CFI. And thank you for your attention.
Great. Thank you, Dr. Weingarten. Now it is my pleasure to bring in Cyrus Jahansus. Dr. Jahansus is an assistant professor in colon and rectal surgery. As a surgeon, he works to improve patient outcomes following colorectal surgery by modifying and reconstituting the composition of the intestinal microbiome. Dr. Jahansus, can you discuss colorectal surgery and the role of the microbiome?
I would be happy to. So, as a surgeon, my focus is more on how we can optimize the microbiome for surgical recovery. Just to highlight the phenoms that are Dr. Khoruts' donors. This is a poop sample from one of his donors. I'm just kidding. You have to excuse my sense of humor. So my focus is on surgery. The goal is to regulate the microbiota to optimize surgical recovery. There are currently no such interventions that do so. So just to give a little bit of background of what we operate on as colorectal surgeons, well, let's just say GI diseases are a problem in this country and continue to rise. One that reasonably so is getting a lot of attention is cancer. Colorectal cancer is now the third most common cancer, and second leading cause of cancer-related death in the US, 150,000 cases annually. Perhaps the scariest is that it is now the #1 cancer under the age of 45 at an age that we do not currently routinely scope, folks. That is significantly higher than if you were 40, if you're 40 years old now versus if you were 40 in 1980. The risk has significantly increased, and to Dr. Weingarten's point, I don't think the change in genetics over a 50-year time point is the underlying cause. Secondly, diverticulitis is also on the rise. You can simplistically think of this as the equivalent of an appendicitis of the colon. Little outpouchings develop over time. They can get infected, lead to infections, now known as diverticulitis. It leads to 200,000 hospitals per year. It is with cancer, one of the leading causes for a need for undergoing elective and emergency colorectal surgery. It is not as well advertised. It is also has terrible consequences. And then the third most common indication, inflammatory bowel disease, certainly Crohn's and ulcerative colitis, need no introduction themselves. They affect 3 million people. Up to 3/4 of Crohn patients require surgery within their lifetime, up to a third of ulcerative colitis. What do all of these diseases have in common? Well, surgery is a mainstay component of it. So naturally, what my group seeks to do is how we can improve post-surgical recovery and outcomes related to each of these diseases. So what is a common current clinical scenario? Let's say you are a patient who needs to undergo a partial colectomy for one of these reasons. At this point, it's standard in the United States that all patients receive mechanical bowel prep, cleansing of the soul as well as the gut, along with oral antibiotics the day before surgery. In no other scenario do we do this in medicine. Then folks get additional IV antibiotics at the time of surgery because they do lead to a reduction in surgical site infections, of which colorectal surgery, and I'll touch on this, is a major problem child for. After surgery, we do nothing for the gut. Now, after which we've just hammered out. No microbial repopulation. Patient stays in the hospital for however many days. So then I got to thinking, what does the gut microbiome look like after surgery? Looks like this. This might be even prettier than what it looks like from a microbial standpoint. Well, we studied this. We found that, so our hypothesis was initially, among the few that we've gone down the rabbit hole over the last several years, is that the combination of surgical bowel prep plus the dramatic effect of surgery on the body as a whole leads to significant changes in the composition after surgery. And that is, in fact, what we see. While we are really good at getting rid of a lot of the bugs that are in the gut, unfortunately, non-selectively, both good and bad, we are still not accounting for a couple of major bacteria that directly, mechanistically lead to problems after surgery. These two are bugs that we found that continued to expand significantly, exponentially in the gut in the post-surgical setting. Not really ideal. Enterococcus and streptococcus are major bacteria that cause infections. As I touched on, this is a major problem in surgery. What do you expect to happen when it comes to colorectal surgery? Well, in the picture here, this patient has undergone a partial colectomy. What you expect is you excise a component of the colon, you put the two ends together, you expect everything to heal beautifully, right? Well, there are certain circumstances where that's called an anastomosis. And if that anastomosis doesn't heal, you're dealing with devastating, life-altering complications. Even if there are certain circumstances, as we discovered, that even if you put 1 million stitches connecting the heck out of those two ends of the colon, if it's not physiologically optimized to heal, it will break down and lead to problems. So why do Enterococcus and Streptococcus matter? Why does the microbiome matter in a field of surgery? You think it's all technical and all that. Well, not unexpectedly, biology and the body's capacity to heal plays a major role. About a decade ago, our colleagues from the University of Chicago identified the link that connects Enterococcus to complications after colectomies. Basically, what Enterococcus, and then more recently Streptococcus being identified, is their potential to produce collagenase. Well, with any scarring, let's say you put two ends of the colon together, the natural healing that occurs is that while you have put the two ends together, whether it's staplers, which we commonly use, or sutures, you need the body to take over, scar it with collagen, and then go from there. These bugs are major producers of collagenase, which breaks down collagen, and that's the link. They essentially expand in the gut after surgery, degrade that collagen that your body is trying to implant and allow that connection to heal, breaks it down, and then we are in a world of hurt. Anastomotic leaks are devastating complications. They're probably the number one thing that keeps surgeons up at night. They have significant impacts on morbidity, mortality. If you need chemotherapy, mortality increases 20%. Healthcare cost triples, oftentimes need additional procedures, operations, whatnot. It's just not fun. So Enterococcus, just to touch on lightly, we found that our bowel prep is just not good enough. The antibiotics that we're giving are not very good at just making sure that the Enterococcus clears out and stays cleared out. But where the heck is the Streptococcus coming from? This is something that our group recently found. So basically, just to touch on this, I'm a colorectal surgeon. Never did I think I would ever envision thinking about what the mouth is doing to the gut. But we got to start thinking. Actually, my partner, Dr. Staley, thought about this. When the bowel prep that we give is very effective at clearing out the colon. But what's not as well recognized is, or maybe more recently is becoming more recognized, is a close second in terms of density of bacteria is the mouth. Streptococcus is the most abundant. So we sought to figure this out, see if, because as Dr. Khoruts alluded to, you got to know mechanism. I think mechanism is a key component to understanding how you can really evaluate the efficacy and really hone in on having an intervention that makes a difference. So that's a recent discovery where we found that Streptococcus is actually coming from the mouth to go into the gut and wreaking havoc. So going to the aims then, one thing we wanted to do, aim one, characterize the relationship between oral and gut microbiome. Is there a relationship? Or are we just thinking way outside the box and we're in a different box? Secondly, identify a strategy to reconstitute the composition and metabolic function after surgery. And thirdly, how can we apply a strategy, develop a strategy, and apply it to postoperative protocols to allow a seamless transition? So let's start with this first one. So in order to identify how we're seeing the gut colonize after we eradicate, we took a look at two small groups of patients. One group of patients undergoing colonoscopy. So the difference here between surgical prep and colonoscopy prep is, well, the prep is pretty much the same, except for the added antibiotics that we give to surgery to truly eradicate, or at least significantly reduce the bacterial load. Colonoscopy patients are just undergoing that mechanical component. So we took a look at a small group of both patients, compared exact time points of both spit and poop to see how similar or dissimilar they were. We found that in fact, in both groups, Streptococcus in the stool samples during the time of the intervention actually went up. So the y-axis of this graph shows relative abundance, so relative percentage of the total bacteria in stool. On the left, three bars are going to be your colonoscopy arm. Your orange bar is going to be your surgical patients. And even in the colonoscopy arm, highlighted in green, you see a pretty good increase in Streptococcus. But when you really blast the heck out of the gut, Streptococcus in the surgical arm takes off. On average, it's somewhere between a quarter and a third of the relative abundance of the gut, highly problematic in the post-surgical setting. So this is all correlative. How can we get a little bit stronger? Well, we did a little extra math and took a look at taking a look at the specific strains to see if, in fact, we can show with a little bit stronger evidence if in fact there is a particular strain that's moving from the mouth to the gut. There still is some streptococcus in the colon, maybe something in the colon is expanding. Well, on the left side, so this is your relative composition among the streptococcus bacteria. There's 3 dominant strains for the simplicity of this talk. We'll just say blue, orange, and green, 1, 2, and 3. So what's not as well seen, or at least not as abundant in the gut after surgery, in stool, is the second strain that highlighting in orange. Well, that's exactly the strain that really blossoms out after surgery. And so based on the data we've accumulated, we've identified that we might be missing a whole potential arm of how our body is reconstituting the gut after surgery. So that drives home, I think, the enterococcus streptococcus piece in really fine-tuning how we can start to attack these bugs in reducing their pathogenic expansion in the gut after surgery. Secondly, well, it takes more than just getting rid of the bad bugs. Can we actually restore the composition and its ecology in the gut after surgery? That was our next question. And this is where we actually took a bit of a turn into diving into MTT, as mentioned, microbiota transplant therapy. So backtracking a little bit, as I mentioned, all surgical patients undergo this surgical bowel prep. So rather than trying to modify that to keep some of the bugs that are there, that may very well actually be causative in cancer, diverticulitis, or what I'm driving some of that disease, why don't we just take advantage of this time period? We've cleared the heck out of everything. Why don't we just take advantage of that ecological opening we have and completely restore the gut with the bacteria of our healthy donors? And that's exactly what we did. So in this initial trial, which we have since built on, we proposed that transplanting patients 2 days after surgery is probably the best time. Why 2 days? Well, IV antibiotics, as I mentioned, are given on the day of surgery. Those take 48 hours to clear out. You got to have those clear out, otherwise they're going to kill the bugs that you're going to give. But then it takes a few days after that, presumably, for your health, for the flora to start trying to come back. So the advantage here is everything's cleared out. You don't have the antibiotics, and you don't have potential competitive competition from the flora there in reducing engraftment. So the other thing is, how do we give it? As Dr. Khoruts mentioned, colonoscopy is pretty much is a standard way of administering the transplant, or it has been. Well, we have a brand new connection. No surgeon, including myself, would ever want to blow up your brand new connection, stressing it out with CO2. That scares the heck out of us, out of technically disrupting our connection. So then we had the idea of potentially introducing it from above, from a feeding tube. Feeding tube, it's a skinny little tube that's placed through the nose down directly into the small intestine. Why in that fashion? Yes, it is an added step, but we needed proof of concept. This whole idea after surgery was fresh. We wanted to see if we can establish feasibility. So a feeding tube is placed 48 hours after surgery, and it's directly injected into the small intestine, bypassing the acidity of the stomach as well as the bile acids of that beginning part of your small intestine. Pretty caustic things that may lead to problems in allowing the microbiota to pass through. And then afterwards, under the close monitoring regulation of the FDA, we monitored fecal samples and watched our patients. So in short, is engraftment possible? Yes, it is. This is just a graph of donor similarity. On the y-axis is a percentage showing how similar patients become to the donor. It's important to note, even within ourselves, 100% similarity. The microbiome is a vacillating composition, changes during the course of the day. But suffice to say, donor engraftment is definitely achievable. And we saw that in all 12 of our patients. We're up to 15 now. And so we are seeing that consistent engraftment across the board for both cancer as well as diverticulitis. Also notably, that pathogenic nuisance of a streptococcus, that abundance was also significantly suppressed. So on the left, we have our control arm, basically identical patients who underwent identical operations to our transplanted arm, but with no MTT. We, as mentioned, saw that spike of streptococcus, and then it abates later on with MTT. We saw a significantly less spike and then a more rapid decline by postoperative day 14 towards pre-op levels of streptococcus. So a significant difference. Thirdly was function. As Dr. Weingarten mentioned, the microbes do a lot. They not only do a lot by their presence, they make a heck of a lot of metabolites. A group of metabolites that have been shown to be essential for the maintenance of gut health are short-chain fatty acids. These over and over in mouse and rodent models of surgery have been shown to be very impactful towards enhancing anastomotic healing and reducing complications. On the red bars show what happens to patients after surgery, 2 weeks after surgery. They are obliterated. These are the three most abundant short-chain fatty acids, acetate, propionate, and butyrate. They are, in a lot of patients, were actually undetectable. With MTT, we saw levels exponentially rise, as you could see. This was extremely exciting to see. This showed to us that not only are the bugs getting there, but they are actually doing what they should be doing, and can only hope and presume that these compounds are helping the gut heal a little bit quicker. So that was our second. MTT provides robust microbial recovery. Great. Third, that feeding tube, that is a problem. Now we need to figure out how we can make this a little bit more streamlined so that it could fit into our enhanced recovery protocols, which has become more of a modernized component of surgery to enhance recovery after surgery, essentially what it says. Get patients quicker in and out of the hospital so they get more into their natural environment and recover quicker. So this is where we started to test our oral suspension equivalent. This is where you drink Dr. Khoruts' magical chocolate milkshake with the suspension in it. Everything else was identical. 48 hours after surgery, we did this across 2 different donors. So a group of 12 patients received a sample from one set of donors. A second donor was used for the other 6 patients. Idea here, well, I'm assuming maybe it gets easier than this. I can't think of a way that it gets any easier than just drinking chocolate milk on day 2 and seeing what happens, and hopefully that does the trick. This would overcome our main barrier of making this widely applicable across a variety of hospital settings. So what do we see? We saw similar engraftment to the donor. This is comparing our across our 2 trials, our 2 arms. The NJ is your nasojejunal feeding tube group. That's in orange. The blue is your the milkshake group. And by and large, across the board through 6 months, occurring immediately after surgery, we saw similar levels of engraftment occurring with both donors. Short-chain fatty acids also improved. This was also exciting to see. Perhaps it was not as robust yet as with the feeding tube, but sure as heck, you saw a significant increase across all 3 short-chain fatty acids with the drinkable variety as well. As a side note, what happens to Streptococcus 2? This bloom is also abated after surgery as well. So at least this can mitigate this guy from causing problems in the gut. On the left, just to rehash what we had before, In our non-treated patients, our standard control patients, that orange bar expands significantly after surgery. In our trial patients on the right, you get that inpatient bloom right during the in the perioperative period before transplantation, but then by day 14, no evidence of it hanging around anymore. So altogether, our third result, oral formulation of MTT, seems to provide equivalent engraftment and functional improvement and outcomes as feeding to delivery. So at least very promising results. Our set of conclusions. There is severe dysbiosis after surgery. This is very much underlying still the persistence, although improved, persistence of complications after surgery. Our work highlights the feasibility of introducing healthy flora back into the colon at a critical time in recovery. And then lastly, more tests are indeed needed to determine the clinical benefit, not only pertinent to surgery itself, but longitudinally to the underlying reason why patients are undergoing surgery. And I obviously would love to thank my collaborators, whatnot, and appreciate very much the long-standing years worth of work we've done together. And that's that.
All right, great. Thank you again to all our panelists. We will now move on to questions submitted by our attendees. As a reminder, you can still submit your questions to our panelists using the Q&A box, which can be found by clicking on the Q&A button at the bottom of your Zoom screen. We're going to jump all the way back to the beginning. We'll start with a question for Dr. Khoruts. And it's a very basic question. So what do we know about how to prevent infections like C. diff when antibiotics are prescribed?
It's an excellent question, frequently asked, and I always scratch my head how to give something useful to say because C. diff infection is kind of bad luck. But the main part of the answer is the sad reality is that antibiotics are overused, and there needs to be some vigilance with regards to that. Study after study show that about 50% of antibiotic prescriptions are either inappropriate or do not follow professional guidelines. It's an easy thing to do, just to write a script. The patient is happy, they got a prescription in their hands for whatever problem it is, but it may be inappropriate. So clearly, we believe in the germ theory of disease. Infections do cause problems. Antibiotics are life-saving in many circumstances, but there can be a price. They cannot be used always with impunity. There could be complications, and therefore, certainly if you're in the emergency room in septic shock, there's not much time to think. There you have to give antibiotics. But for most of the time, it's reasonable to question, is this really needed? That's the main what one can do and probably one should do when they visit a doctor.
Great, thank you. We'll pivot real quick. Just a quick question for you, Dr. Jahans, who's off of that. Is it necessary to get IV antibiotics prior to surgery?
If we don't, your infection risk is double based on what we know right now. So the data is pretty clear on that.
Great, thank you. All right, and then we'll pivot here to Dr. Weingarten. There's a question related to, can celiac disease be cured? And we'll follow that up with, how does the change in wheat grown in the US specifically potentially impact things like celiac disease?
Yeah, good question. So as we currently, there is no cure for celiac disease currently. Hopefully there may someday be. Right now, the only treatment that's approved for celiac disease is just to avoid that gluten protein. There is some emerging work trying to reverse those immune changes. So again, I talked about those inflammatory T cells really triggering the disease when they see those gluten proteins, and there's some work trying to reverse that, which could effectively be a cure for the disease. But that's there's a lot of promise, but we're definitely not there yet, unfortunately. And then the question about whether different types of wheat grown in the US or elsewhere could be involved with the increasing prevalence of celiac. And the answer is probably not. Maybe I should back up a step and first make sure that first what I'll address is the issue of celiac disease specifically. So that's this very specific abnormal immune response to these gluten proteins. That's distinct from potentially distinct from gluten intolerance. We often think of gluten intolerance as being, or I think of it as non-celiac gluten sensitivity. So individuals who don't have these same immune changes, but still have symptoms with eating gluten, and it's probably a separate disorder. So with regards to celiac disease specifically, just looking at epidemiologic data, there's actually very similar rates of celiac disease around the world. And that includes Asia, Africa, Europe, and the US. So it's probably unlikely that differences in the types of wheat or in agricultural practices in the US are driving the rise in disease that we're seeing worldwide. That said, if you go back to literally ancient history, we do think that celiac disease as a disease probably began to be an issue with the rise of agriculture in general. So, and we know if you are never eating any of wheat, barley, rye, any of the grains that contain those problematic proteins, you will not get celiac disease. So you do need to be eating them, but differences in wheat between the US and elsewhere around the world, I don't think can explain the increase in the rate of celiac disease. The gluten sensitivity, so unfortunately, we don't really understand very well what drives that condition. So it's hard to say. It might actually be a response to components in processed foods that contain gluten, but not an actual response to the gluten itself. So it's kind of, I think there's a lot more unknowns about that condition right now. Could it be related to agricultural differences between here and elsewhere in the world? It may be, but I think we just don't know enough about it to say.
Great. That sounds good. Thank you. Next question is primarily for Dr. Khoruts, but I think it's definitely relevant to Dr. Johansus too. So the question here has to do with the idea of kind of like an ideal donor or an ideal donor's microbiome. So like once you have a good batch of FMT material, can't you just grow that or ferment it in some sort of way so you can just continue to use that without the need for donors? And then kind of the follow-up question to that is also like what features of a donor microbiome are more beneficial in certain cases, and maybe that's something that Dr. Johansus is seeing in his work.
That excellent question. It is frequently asked, particularly people who are kind of thinking about business development. And I think it's a twofold answer. First, it'll be approximately year 3047 when humans will be able to put together something that nature's put together in a bioreactor. It's just simply not, we're not that smart yet and won't be for a while. That doesn't mean that there's not some companies pitching the idea. But the reality is when you put the microbes in a culture, literally within a day or two, there's some microbes that will grow out that are actually really good at growing in the bioreactor and are not helpful at all and probably pathogenic. So that's one answer. It's just not practical. It's not practical from a regulatory standpoint either, because really to put something together, you won't be able to do it as a one culture. You actually have to grow one microbe at a time in a good manufacturing practices facility. The closest that I know that anybody has done that work to is a group at Stanford that isolated 150 different microbial strains, and they think they're going to test this consortium in a phase 1 trial at some point. The second part of the answer is there is no such thing as ideal donor, because It depends what you're trying to do. For example, in C. difficile infection, really any healthy human microbiome will do. You're just trying to repair huge damage with depletion. But there are some conditions where there's a specific physiologic function that you're looking for. And we know we have some examples of that, and we know there's a great variability among donors in that particular function. It doesn't mean that for something else, a donor A is really good for disease B, but not so good for disease C, and a donor F is really good for disease B, but not, it goes like that. So that's actually a lot of our current work is trying to stratify natural microbial communities for different indications. And this is kind of a top-down kind of approach toward rational development of therapeutics rather than bottom-up where we just pretend we're gods and you're just going to build it from scratch.
And so from our part, I think to piggyback on Dr. Khoruts' point, I mean, there's a lot of functional redundancy within the microbiome too. I mean, I mean, the goals that I think we envisioned setting out for post-surgical patients was, can we get rid of the bad bugs? Can we restore some semblance of commensals? And can we get them to do what they do in healthy people? And in that regard, even though there's variability with whatever the patients take up from the donor, we're seeing those three missions. And so it's not, I completely agree. You have to be mission oriented towards figuring out why you're doing it, when you're doing it, whatnot. And in that regard, yeah, we're seeing some correlations, but by and large, I mean, you're seeing an improvement in diversity in those functional aspects of it. So,
yeah, great, thank you. We'll move back to Dr. Weingarten. First is a bit of a clarification, sort of a question, but then we'll follow that up. So, is cow's milk allergy synonymous with lactose intolerance? And then, as it relates to lactose intolerance, does lactose intolerance affect the gut microbiome?
Yeah, good questions. So no, cow's milk allergy is distinct from lactose intolerance. Cow's milk allergy is, again, it follows the same immune pathways I talked about. And it's a response to one of the proteins in cow's milk. Lactose intolerance is basically an inability to break down the major sugar in milk, the lactose. And when you're missing the enzyme or there's intestinal damage or something, you can't break down that sugar, then it gets into the colon, it gets further into the intestine, and then the microbes that are living there go, ooh, tasty, tasty food, and then they start metabolizing it and making the gas that causes the bloating and the diarrhea that leads that you experience if you have lactose intolerance. So they are distinct entities. And as you might guess, based on how we think lactose intolerance develops, yes, there can be changes to the gut microbiome. But it's suspected that there may be differences that potentially could predispose someone to have lactose intolerance, right? You do need the inability to break down that sugar in your own body, but what those microbes in the colon do with it once that extra sugar gets there determine whether or not you're going to feel symptoms, right? So if you have bugs that don't really care about it or they're not making a lot of gas, you may feel fine even if you can't make the enzyme. And then there unsurprisingly, if you give microbes like to eat a whole bunch of different stuff that humans can't necessarily digest. So if you give them a whole new energy source, you might have certain bugs that get really happy with it and grow out and form a larger population than other bugs. So yeah, you can see changes in the microbial community as well with lactose intolerance.
Great, thank you. Next question will be for Dr. Johansus. So someone is asking, it's a very good question. I guess, what is the rate of anastomotic leak that you're seeing after these intestinal surgeries? And are you able at this point to comment on whether or not you're seeing a reduction in the rates, or are you going to need more studies for that?
So leak rates, vary by centers. If you take a look at the most recent trial that compared bowel prep or no bowel prep after surgery, you have a risk of 12 to 15%, which seems a little high. This is in Europe. Without bowel prep versus with prep goes down around half that. At big centers of excellence, you're probably around 3 to 5%. But that also varies depending on what part of the colon or rectum you are cutting and resecting. What I will actually submit is that there's an array of, I think, associated post-surgical issues that I think are linked back to the microbiome. I would argue not only anastomotic leaks, but there's a big risk of ileus after surgery. That's somewhere between 10 and 30%. Ileus is where you don't have a bowel obstruction, but your bowel has gone deathly to sleep. It stops peristalsing and it's stuck. It just ain't working. It's functionally stopped for a little while. That is a major problem. Actually, that's one of the leading causes for delayed discharge after seemingly a technically perfect operation, but also the surgical site infections as well. So I think overall, while leak rates remain as low as we can get them with all the technology, and I don't know how much smaller we can make the darn robot doing these things, there's that myriad that I think is underlying the biology that we just are not doing, in my opinion, enough about to optimize outcomes after surgery.
Great, thank you. And then the next question will be for Dr. Khoruts. And we'll start it with what's the rationale for treating autism with a microbiome intervention? But then there's quite a few questions related to gut-brain axis. And so we'll just kind of expand it out in what is kind of the role for the microbiome in broadly this idea of the gut-brain axis, and what is that?
The interest in autism in this field was sparked by small trials, like a couple, 2 decades or more ago, where um, patients with autism were treated with an antibiotic, vancomycin, and there was a transient improvement, but it was not sustained, and you couldn't keep people on vancomycin forever. So that at least focused attention. There could be something in the gut microbiome. Now, what we know now is that the gut microbiome is a physiologic organ in the body. It makes a lot of chemicals. So recently, a group I'm affiliated with has been able to show that they can tell from a urine test with 90% confidence of who has autism and who is a typically developing individual. And what do this urine tests show? It's showing microbial metabolites. So there has been some recent controversy. Why are we thinking about microbiome when most of the autism is actually genetic? And yes, there are some monogenetic disorders that are characterized by severe autism. Most of it is thought to be polygenetic, that is, multiple genes are involved. But about 90% have a genetic component. We know that from twin studies and such. So why are we looking at the microbiome? That's not genetic. Could be if there's a, you know, a passage of microbiome from mother to child and the family and such. But we now have just finished a randomized control trial in a monogenetic disease where we know the single gene that affects neural development, and we targeted the microbiome, and the patients did better with the active treatment than with the placebo. So the gut microbiome is a modifiable target. It's not a cure, but what a lot of patients with autism suffer with GI symptoms, more than half do. If they're nonverbal and they cannot really find help for their tummy hurts, they may have behavioral issues. That could be one mechanism, but there could be other mechanisms where it's directly metabolites affecting neural function and neural communication. And there are certainly candidates, molecules like that can have neuroactive properties.
Great, thank you. So thank you to our panelists today for your time and for sharing your insights into current and potential treatments targeting the microbiome. We would also like to thank all of you, our participants in the Mini Medical School, for joining us in this series. Have a good evening.